Why don't doctors treat high blood pressure by simply prescribing a single massive dose of medicine to force the numbers down? The cardiovascular system is a highly reactive, closed-loop network. It interprets any sudden, blunt force drop in pressure as a threat to survival, and it will aggressively fight back to restore the original state. To understand this defense, look at the hemodynamic equation. Blood pressure equals cardiac output multiplied by systemic vascular resistance. Dropping vascular resistance tilts the equation. The heart panics at the sudden pressure loss and beats faster to compensate, driving cardiac output right back up. The pushback doesn't stop at the heart. The kidneys sense the pressure drop and dump renin to constrict vessels, while the sympathetic system unleashes adrenaline. Treating hypertension requires managing the body's internal regulatory alarms by targeting multiple physiological systems simultaneously. Historically, high blood pressure was often viewed as a static measurement, a solitary number captured on a dial. Functionally, it is relentless mechanical shear stress scraping against delicate vessel walls, minute by minute over decades. The heart muscle bears the initial brunt of this target organ damage. To push blood against high resistance, the left ventricle physically thickens, developing into left ventricular hypertrophy, which compromises its ability to relax and fill properly. Out in the macrovasculature, this continuous high-pressure flow accelerates coronary artery disease and threatens to tear the inner lining of the aorta, risking a catastrophic dissection. At the microvascular level, the pressure forces its way into the kidneys, physically destroying the delicate nephrons responsible for filtering the blood. High blood pressure is a structural degradation of the entire cardiovascular plumbing system. Arresting that damage requires a targeted defense. Building that defense means selecting from an arsenal of drug classes that selectively target specific physiological pathways. The first line of defense often relies on diuretics, like thiazides and loop diuretics. They act by blocking sodium reabsorption in the kidneys, forcing the body to excrete sodium and water, which lowers the overall extracellular fluid volume and takes pressure off the pipes. This diagram illustrates exactly where that mechanism occurs. As the filtrate moves through the nephron loop, these colored arrows map the movement of ions and water that diuretics interrupt. But forcing sodium out drags other electrolytes with it. The primary side effect is hypovolemia, a dangerous loss of potassium, along with metabolic shifts that demand close clinical monitoring. Next are the ACE inhibitors and ARBs. These drugs jam the renin-angiotensin-aldosterone system by blocking the production or the receptors of angiotensin II, preventing intense systemic vasoconstriction. They also execute a crucial localized maneuver. They specifically dilate the efferent arteriole exiting the kidney, allowing blood to flow out more easily and immediately relieving pressure inside the filtration unit. Because ACE inhibitors also block the breakdown of bradykinin, about 10 to 15% of patients develop a persistent dry cough. When that happens, doctors pivot to prescribing ARBs, which block the same pathway without triggering the cough. Diuretics and ACE inhibitors both lower blood pressure, but they rely on entirely distinct mechanics. One drains the fluid volume, the other relaxes the tone of the vessels. Calcium channel blockers, or CCBs, take a different approach. They slam shut L-type calcium channels on cell membranes, preventing calcium from entering the muscle cells and forcing them to relax. The dihydropyridine subtype of CCBs, like amlodipine, specifically targets the smooth muscle in peripheral blood vessels, causing them to widely dilate. This wide dilation leads directly to their main side effect. The relaxed vessels allow fluid to pool in the extremities, often resulting in peripheral edema around the ankles. Non-didipyridines, like verapamil, largely bypass the peripheral vessels. They directly target the heart muscle itself, reducing both the heart rate and the force of contraction. Beta blockers also target the heart, but they do it by capping the sympathetic nervous system's beta-1 receptors, blocking adrenaline from binding. This physical blockade lowers the heart rate, reduces the squeezing force of the cardiac muscle, and simultaneously inhibits the kidneys from releasing renin. However, beta blockers can also affect receptors in the lungs, triggering bronchospasm. This makes them strictly contraindicated for patients with active asthma. CCBs and beta blockers are powerful tools, but their direct impact on the heart requires precise patient matching to ensure the cardiovascular pump keeps functioning smoothly. Pushing any single pharmacological pathway to its maximum dose inevitably triggers a severe reflex side effect from the body. Rational combination therapy utilizes lower doses of multiple drug classes to achieve physiological synergy. A diuretic successfully shrinks the fluid volume, but the body senses this loss and hits the panic button, activating the RAS system to release potent vasoconstrictors. Adding an ACE inhibitor perfectly blocks that exact RAS rebound. It intercepts the chemical signal, neutralizing the body's defense mechanism before it can raise the pressure. They also share an elegant potassium synergy. Diuretics cause the kidneys to waste potassium, while ACE inhibitors cause the body to retain it. Administered together, they cancel out each other's toxicity. The effectiveness of combination therapy stems from the direct neutralization of reflex mechanisms by the secondary drug in the regimen. In modern practice, the choice of a primary antihypertensive is rarely arbitrary. It is dictated directly by concurrent organ damage. Consider a patient with diabetes or chronic kidney disease. Their glomerular filters are strained under high pressure, causing protein like albumin to physically leak into the urine. This KDIGO flowchart mandates initiating an ACE inhibitor or ARB, even if systemic blood pressure is completely normal. They act like a wrench, opening the efferent arteriole to relieve intraglomerular pressure and stop the albumin leak, requiring the mitigation strategies shown here. A heart failure patient presents a different profile. Their left ventricle is dilated and weak, actively failing in its role as a pump. For these patients, beta blockers and ACE inhibitors are mandatory. They halt the toxic neurohormonal cascade known as ventricular remodeling, stopping the heart from altering its own shape and improving long-term survival. But for a pregnant patient, ACE inhibitors and ARBs are absolutely contraindicated due to severe teratogenicity, meaning they will cause profound developmental harm to the fetus. The guidelines demonstrate that a drug's secondary, organ-protecting mechanisms often becomes its primary clinical indication. Some cases refuse to yield. Resistant hypertension is defined clinically as a patient whose blood pressure remains uncontrolled despite taking 3 or more drugs, including a diuretic, at maximum tolerated doses. Achieving blood pressure control in these resistant instances often necessitates the addition of spironolactone, an aldosterone antagonist, to inhibit the final stages of hormonal sodium retention. There is a critical difference between a patient who simply has very high blood pressure and a true hypertensive emergency. An emergency is strictly defined by a pressure over 180/110, occurring simultaneously with acute visible end organ damage, like papilledema or encephalopathy. In these scenarios, dropping the blood pressure too quickly is a paradoxically dangerous move. The brain's blood vessels have adapted to the high pressure, and a sudden drop can easily trigger an ischemic stroke by hypoperfusing the brain tissue. This requires carefully controlled, highly titratable intravenous interventions in the ICU to step the pressure down safely over hours or days. Treating hypertension requires a multifaceted assessment of the heart, kidneys, and vasculature to deploy drug combinations that provide systemic protection beyond a single data point on a monitor.